Yeah, it's a tough title. The There's a lot going on in this topic,
There's a
I
lot going
feel.
on there too. I think we just do cases basically,
Yeah.
um, because then it just helps people clinically. I think like we can talk about the different kind of presentations, but we'll just do kind
Mm,
of one of each. GP experience.
mm.
Most. How often do you actually find out the cause of brain disease? Would you say, like, if you've got a patient that
Next
comes
to
in,
none.
next to none?
Yeah.
Yeah. So that's
Because
what.
specifically with brain disease, I find with treatment options so limited that
Mm-hmm.
doing the diagnostic process won't change the outcome.
Mm,
And for owners, it's a hard step for them to get across to go ahead with diagnostics when it's not going to change. Well,
yeah.
specifically with structural brain disease,
Yeah.
um, that they're going to pay that amount to not
Yeah.
change their outcome.
Yeah. Totally. And the things like, if it's a stroke, it'll get better. If it's
Mm.
not, then it won't. So
Yeah,
that almost like waiting is diagnostic test in itself.
yeah,
And often a stroke is secondary to neoplasia anyway, so it's kind of it is hard with these ones. And I think this is such a topic where referral medicine is like, oh, this is really interesting, and let's like, like this presentation, we should do this because we're seeing this like less than 1% of clients who can and want to have that answer and know that they've done absolutely everything possible and
mm,
would potentially pursue like removal of a brain tumor if it's appropriate and stuff. So it is very much a referral medicine kind of topic. So I chunked a lot of subjects, like a lot of diseases, into this one topic because I don't think it's worth talking about these in detail
yeah,
because they're not that relevant clinically. They are potentially relevant from an examination perspective because often it's people working in referral settings that set the
mm,
exams. So we will kind of just talk about what hints you can get that it's like vascular versus neoplastic and
yeah.
stuff. Um, okay, so where should we start? Okay, let's start by what sort of historical clues you might get to help you like narrow down your differential list. If a patient presents with, essentially, I'm going to just say four brain signs, which would
Yeah.
include what? Sorry, I'm going to drill you. Sorry.
That's fine. That's good.
All right,
So lethargy, dullness, ataxia,
good.
essentially any broad change in behavior, I guess, could be linked to some kind of neurological central brain disease.
Yeah.
The main signs that I would personally look for would be acute versus chronic. So I think an acute one would be much more common for your vascular type
Mm-hmm.
disorders, where um, more chronic could indicate space occupying mass lesions.
Mm.
Um,
Yeah.
and behavioral, I mean, yeah,
Mm. Um, yeah, behavioural change is a big one, and it's often, particularly with like brain tumours, it's subtle. Like it happens, like they're just quiet today, and then they're a little bit more quiet, and you're like, well, they're old, that's expected. Something that when because I just usually sit on the floor and watch dogs move around,
mm,
and often we see these guys when like kind of GP's done all of the diagnostic tests and they're like, just it's nothing really like making me think intracranial, but I kind of ruled out everything else as a cause of kind of dullness. So I often just sit on the floor and watch these dogs move around, and often they stare into space, so they're almost vacant. And that's not really a sign that people describe, but that's something I kind of ask for now. Like, do they do that often? Um, Head pressing is a big one that people kind of sometimes don't think to mention, but that's like
mm,
you or I going like that. Like it's that dog's got a headache.
yeah.
Um, and then another
I find
one,
specifically one there's like they're seeking kind of low stimulus areas of the room, so that
yeah,
they're finding the dark, they're finding those places that they can just yeah,
got that. Yeah,
yeah, it's
I
feel bad for
got a
them.
migraine. You can relate to
Yeah,
it. Put your
yeah,
titties
yeah,
on.
yeah. I do that on a Sunday morning too. Wait a second.
Oh dear. Um, I won't expand on that. I would not. Um, yeah, another thing I ask about how their appetite is, and then I
Mm,
go into a little bit more detail about that because often um, clients will say, "Oh, they're just eating a little bit less." But when I say, "Okay, do you mind if I like put a bowl down and watch how they're interacting with that bowl?" Often it's that they don't want to put their head down. You know, when you've got a headache and you put your head
yeah.
forward, and you can sort of see them kind of get down low and just go, "Oh, I can't be bothered. It's not worth it." So
In GP land, I often really struggled with these cases because they're often those older dogs with a bunch of
uh,
comorbidities as well. And you go, is
chronic,
this
yeah,
an arthritis? Is this some other
mm,
disease that's going on? Is this, is this, or can we narrow it down? Because the symptoms of intracranial disease are so broad
mm,
that they're
yeah.
never going
If
to
there's
be
not
specific for that,
seizures,
really, unless they're circling or there's nystagmus or anything like that. But
circling
um,
seizures, they're the big ones. Yeah.
yeah, yeah, or seizures.
Mm.
So yeah,
Another one is vision, like particularly kind of low light vision loss. Um, so central blindness can develop over time if there's increased intracranial pressure. And that kind of manifests in low light, becomes more obvious first. So they may still have a menace because they've got a little bit of vision. So it's harder to tell clinically, but I sort of sometimes say, is there any change in vision? Again, there's often comorbidities associated with like nuclear sclerosis and stuff. Is that what it's called? Yeah.
yeah, yeah.
Yeah. Or cataracts or whatever other
Just that,
option.
yeah, yeah. The opacity of the
Madness.
cornea. Yeah,
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 exactly. So often it's a very much a vibe that makes me go, I think it's probably
yeah.
worth doing imaging. What are the two different diagnostic tests we can do?
CT MRI.
Yeah, pretty much. Yeah.
Yeah.
They're the only
Or
two options.
do you get much value from a spinal tap from intracranial disease? No.
So often, whatever the process is, if it's actually like in the brain, it's not in common with the ventricles. So it never
Mm,
sheds into CSF. So
mm,
sometimes crypto, like that's kind of the only process that happens as a mass lesion in the brain that will show up on CSF. But the LCAT's such a good test that I'd always just
yeah,
do that one
yeah.
first. Like if they
Mm,
were, when you're talking about like, do you want to spend $160 or 4 grand? That's
yeah.
um, uh,
And the LCAT
yeah.
gives
So
specific numbers now as well, right? So you can be pretty diagnostic for
LCAT's
it.
what?
You, they give specific titers now, right? So it can be pretty
Yeah,
diagnostic. Yeah,
yeah. And if it's positive, it's positive. Like
yeah.
it just if it's positive, it's crypto. It's actually a really sensitive, really specific test. It's a nice one. So
Mm,
you can rely on it quite a lot. There was a run of one of the labs reporting false positives, and at one point, several patients got CTs to investigate or imaging to investigate
mm,
their suspected central crypto, um, and it was a kind of a lab error thing.
mm.
Um, but I'm sure that's been rectified because that was reported and stuff. So it like whilst it's a very good test, all tests are potentially vulnerable to being wrong.
Yeah,
And the nice thing about imaging, as much as like we try and guard people's wallets, it's not really our job. And imaging is very non-invasive. And I think there's a lot of value for a lot of clients in just peace of mind. So
yeah,
if they start Googling, like if you say, oh, tested positive for crypto, they start Googling, it's pretty dramatic Google that they're going to find, or AIing now, times have changed. Talk to their mates, ChatGPT and Claude. So I think that imaging, if they can afford it, is not the wrong thing to do in any situation if you're suspicious of intracranial disease. So, because of the logistics of accessing imaging and stuff like that, a lot of people don't do it. But the other thing I'll say is that CT scans are the first port of call for intracranial signs in humans. They
interesting.
don't,
Okay.
yeah, particularly if there's a kind of an acute setting, just because access to CT is so much easier.
Yeah, okay. Yeah,
And they can just escalate to an MRI with very like no cost to the client essentially. So obviously cost to the healthcare system, but and that's a luxury that we don't necessarily have. But I think we sort of say, oh, I can't get in, we've got to go to a facility with an MRI, I can't get in for a couple of weeks because there's no neurology appointments and stuff. That can be a big deterrent for people, just kind of, and then they sort of go, okay, well, I might just euthanize, or we'll just see what happens, or I'll just take the pred and see. And I don't think the CT is the wrong thing to do if the owners understand that it's not quite as accurate. There's smaller things that we might miss on CT, but you can rule out a big tumour on CT, and that's peace of mind in itself. Like, if they're dull, it's going to be a big tumour. So we use CT a lot because the centres that I've worked in didn't have MRIs, and you're often just in a setting where someone's acutely decompensated and you're like, is their brain herniating? Have they had a massive bleed? Like my clinical questions are diagnosable on CT in the settings where they're kind of urgent and you have to do it. So it's worth doing. And like middle ear infections and stuff like that, really obvious on CT. It's actually better than MRI for ear disease if it's like vestibular stuff. Yes, so they're kind of the pathways that we can go down when a patient presents with intracranial disease. Acute presentations are quite different differentials, right? So we're sort of talking about those chronic ones being most likely tumours, very unlikely degenerative disease, particularly in those old dogs. But what about acute presentations? What's the most common cause?
Would that be seizure? Yes.
Oh, most common presenting sign for sure. I wouldn't say, excuse me, it's the most common presenting sign for an intracranial lesion. I reckon a lot of the older dogs that present with a seizure have quite a long-term history of being a bit slow, and like you're sort of like, okay, there's probably a space-occupying lesion in there. But those acute presentations, you're right, it's probably seizure most commonly. But then what's another way that they might present acutely?
I mean, collapse, nystagmus, head tilt.
It's often kind of vestibular, isn't it?
Yeah.
Yeah. So we're going to do a whole session on vestibular, so I don't want to go down the vestibular like full-blown discussion. But how might you say, okay, well, this is maybe not like idiopathic vestibular. What signs would make you go, okay, this is central?
You'd want to rule out. You'll always check your ear to check the ear infection. Bloods as well. They're typically normal. Age is a big one. Signalment's a big one. Um, the I know there's the type of nystagmus that you see as well. If they are experiencing nystagmus, you have your vertical and horizontal. I think vertical is very indicative of central,
Yeah, it is
and
central.
horizontal can be either.
Yeah, exactly right. Yeah. And if the eyes are doing different things, like if one's going up and down, that's central for sure.
Central. Yeah.
So yeah, if it's vertical, it's central. The other thing is the rate of nystagmus, that people don't talk about it very often. But idiopathic peripheral vestibular disease, it's so fast. The nystagmus is so fast, whereas central can be really slow, like only a few a minute. You're like, whoa, what just happened then? Like you sort of catch it.
Yeah.
Often with central lesions, they will present with a kind of acute onset vestibular disease, but it's not that severe. Or there might be more kind of torticollis, more of a head turn than a head tilt.
Okay.
You know what I mean? Torticollis. It's like that when
I've never heard that term before. That's right.
I'm probably saying it wrong. I asked
okay.
for clarification last week, and somebody was like, "Yeah, you're saying it right," but everybody says that to me. I feel like I need to write it in the chat so that you can. That's so weird. Sorry.
I'm not sure if I said it as well, but circling is one that definitely would indicate central instead of an idiopathic.
Yeah, absolutely. I reckon dogs with peripheral do circle, just to make it tricky.
Okay.
They, uh, uh, because they've got such a severe tilt,
Mm, they just
and
fall and catch
yeah,
themselves that way.
yeah,
Yeah.
I actually find it really hard to assess because often they're
Mm,
not ambulatory.
yeah.
Um, so peripheral vestibular, really fast nystagmus, really severe tilt without much turn in it, typically.
Mm,
And they're rolling like they're doing the crocodile roll often. When they're that
yeah.
severe, I'm usually like, oh, it's acute idiopathic. It's peripheral, or it's going to resolve with time. So sometimes the severity of presentation, I'm like, oh, that's actually a good thing. Whereas when they're a little bit more subtle, I'm like, ooh, it's more likely a slow growing lesion that's had a little bleed or something like that. It's not as
Mm,
dramatic. Um, uh, and dogs with intracranial will often do slow, wide circles, whereas dogs
mm,
with vestibular will do quite tight circles and almost
mm.
compulsive circles. And often the dogs doing the slow circles have reduced mentation. But then
Yeah.
again, it's so subjective because it's happened over time and they're old and slow and often pretty
Yeah.
dull.
Am
Um,
I right in thinking that dogs circle towards the mass in the direction of the mass because it's an inhibition of the inhibitory pathway, so they can't stop going that way or something?
um,
And that's why it's towards the side of the tumor?
they go towards the tumor. It's I don't know about how that. I think that's more that there's just an absence of signals from that area that makes them go
Yeah.
that way. Where the double negative one, the loss of inhibition, is actually the cerebellar lesions.
Right. Okay.
So if you've got, oh, this is gonna like really challenge me. We're not doing a vestibular session, mate. I haven't read up on this. Okay, so if you are like sitting in your chair and you kind of got to stand up. Can you stand up? You got to
hmm
do. Okay. So if you tip to one side, what's the tone in your right leg doing, or whatever way you're tipping?
Not doing much. In the way I'm tipping is
Yeah,
tensed.
tense, right? Okay.
Yeah.
So what happens when you tip? Your vestibular system senses that you're tipping, and it sends a signal, crosses over, and goes down that leg to increase tone on the side that you're tipping to, and then you tip back, and
Mm.
the other way
Yeah.
happens. So if you have a loss of, oh my gosh, blowing my mind. Um, okay.
So it's a loss. So you're supposed to have tone on both sides, but if you lose tone on one, you've tone on the side that you're going away from.
Oh man, I feel like I feel like tone is the default,
Yeah.
and reducing tone is actually the mechanism of the pathway to
Yeah.
balance you out. Oh,
Yeah.
let's talk about this in the vestibular one.
I'm kind of with
And
you there.
so that like there's some sort of double negative there. I don't know where my brain is, but at some point in my career, I knew this really well. We're not there now.
So why does the
This
brain
is
forget things? I mean,
I don't
we've
know,
learned it.
but
Why do you forget? Yeah.
this is why I like doing these tutorials because I never would have questioned. I know that that's somewhere in the
Mm.
archives. I never would have questioned my judgment clinically, knowing about vestibular disease
Yeah.
until you're in this situation where you're like, actually, I can't,
So,
I can't
yeah. Yeah.
remember
Yeah.
that. As it turns out, that's very annoying. Anyway, we won't talk about vestibular disease.
Yeah.
Can
We'll
somebody
just
cut
do it
this
later.
section of the tutorial?
We'll get we'll get Helen to do a little section now on it,
Some
and then we'll cut back
sorting.
to it. Yeah.
Exactly. Yeah. So Helen's on leave. I forgot to explain to everybody. So
Yeah.
this tutorial is going to be a washout. Helen is officially the smartest person on our team. Uh,
Correct.
So some of the what I wanted to get to, as far as like being able to give owners like, okay, it's probably going to get better, or it's probably not worth doing imaging, or maybe it is worth doing imaging, um, is talking about some of the different like kind of really distinct markers of strokes in particular.
Mm.
You know, those acute presentations where they're kind of vestibular, but it's not that bad, but they're definitely neuro. They might be a little bit dull and stuff. So let's say we've got what are the you've got a patient that presents with acute onset vestibular signs.
Mhm.
It's a 9-year-old cabbie. Um, and you're going, okay, is this idiopathic vestibular disease? Is this a brain tumor? Or is this a stroke? They're kind of probably the most common things in that age range. What testing are you going to do in that initial period? You mentioned blood tests, you mentioned
Mm.
um, like physical exam, neuro exam, obviously. What extra test might you do to help you?
As in try to differentiate between central and sorry, as in cranial and extracranial.
Well, to give you a hint of what the etiology of the cause, like the cause of the neuroscience might be.
Okay.
It's kind of a poorly worded question.
But it
Well,
specific test.
I'm
Mm.
getting at blood pressure,
Okay.
actually.
Okay.
Yeah. So anyone that presents with any neuro acute onset neuroscience should have a blood pressure taken. Why?
Mm. Because I would assume that um, there's a relationship between intracranial pressure and systolic blood pressure.
Yes. What is that relationship?
I assume that if one's high, that, or if we go into the Cushing's reflex.
Yes. That's what we're going
Yeah.
to. Yeah.
Um, yeah, that's something that, because isn't this, it would start to, yeah, look, I'm not sure specific.
So the brain's in a hard case. It
Mm.
can't expand at all. So in that case, you've got arterial blood, venous blood, and parenchyma, essentially, and CSF, I should say. So blood, CSF, and brain. And so if you've got brain taking up more space, that's going to compress the blood vessels and it's going to compress the CSF or the like
Yeah.
fluid cavities.
Mm.
So CSF's all right, just kind of it's going to equilibrate to the pressure over time. But the brain has an absolute requirement for blood delivery. So
Mm.
it will prioritize getting blood there by jacking up systemic blood pressure to overcome that external pressure on the vessels and maintain
Mm.
blood flow to the brain. So when you've got really severe increase in intracranial pressure, you will get increased blood pressure, which will do what to the heart rate?
Lower it, should lower it.
Yes, exactly right. Yeah. So
Mm.
your baroreceptors at the aortic outflow are going to detect hypertension and they're going to say, whoa, we don't need that much blood. And your brain's like, yes, we
Mm.
do. Yes, we do. So you get this Cushing's
Mm.
reflex. Yeah. It's actually really rare. Um, they've got to be
Yeah.
pretty severely um, increased intracranial pressure for it to be bad enough for us to detect that. But if a dog comes in really dull and their heart rate's really low, I'm like, ooh, dear.
Yeah.
Um, I've had a dog once that every time I lowered or raised its head, I obviously altered CSF flow and pressure, and each time it would just pass out.
Yeah.
So it was right on the cusp of having like when we did actually go to imaging on that one, and it was herniating its brain. And so that tiny little change in pressure that I was initiating by putting the head up, the neurologists always say don't give the blood sticks from
Mm.
brain injuries or like neuro presentations. That's why, because if you increase
Mm.
pressure in there, that might be the thing that just kind of tips them over the edge. Um, so that's actually a good tip. Don't take jugular blood sticks. Don't include the jugulars. and elevate their head if you do get an acute neuro presentation and the owners are wanting to kind of do more steps and stuff like that. So we usually put them on like a 30-degree incline,
Yeah.
no jugular sticks. And are you going to treat their hypertension?
I would assume not, because that's maintaining the blood to the brain.
Yeah, yeah. You
Yeah.
actually want to treat the hypertension, the increased intracranial pressure rather than the hypertension.
Yes.
Um,
Okay.
so I got off topic and started talking about treatment. Presentation, still at presentation.
Mm.
um, so the most common artery that gets okay, two different types of strokes. What are they?
Oh. Um. I don't know. I'd just be guessing
Hmm. Give me a hint.
in like intravascular
Oh,
or
it's yeah. Actually, you're right. Yeah, that's exactly it. So ischemic, blocking of a
yeah.
vessel, or
Yeah.
hemorrhagic, rupture of a vessel.
Yes. Okay.
So it's
Yeah.
intravascular, extravascular. Yeah.
Yeah.
So we call them ischemic or hemorrhagic.
Yeah.
Hemorrhagic are typically because something's disrupted that vessel. So it might be massive hypertension, like systemic hypertension, that's just
Mm.
blown a vessel, or it might be a tumor, most commonly a tumor.
Yeah.
So that dog that I was talking about, this one had hemangiosarc just all through its brain, and it was a really cool case. Had a left ventricular wall hemangiosarc, so it was just seeding cells into arterial
Oh, straight
circulation
up.
constantly.
Yeah.
Yeah. Yeah, really the most amazing MRI I've ever seen.
Mm.
Yeah, so
Does that mean that
that
it
dog,
metastasized to the heart first if it's in the, oh, no, it was in the left
I
atrium,
reckon it started left ventricular wall,
left
like
ventricle?
the actual meaty like part that does all the work,
Mm.
and it was rupturing into the heart. So it was obviously bleeding, but it was bleeding into circulation,
Yeah.
and just exfoliating cells. So this dog just had like you've never seen like the radiographs of the lungs, like they were just absolutely everywhere, all through the spleen, all through the
Yeah.
like
Right.
absolutely everywhere. Yeah.
Yeah.
Just showered cells all through all the muscles and stuff like that. Like even like looking at the MRI, like the muscle around the head and stuff like that. There was just, it was
Mm.
like the spottiest dog I've ever seen. Anyways, having little bleeds from hemangiosarcomas in the brain. So on MRI, we could see like fresh bleed, old bleed, edema, fibrosis, like in these kind of patterns. So when we talk about ultrasound, so for context, everybody, Anthony and I work together. Anthony's one of our sonographers. On ultrasound, you know, when we see a target lesion, I'm like, ooh, I don't like that. That's because a target lesion is a sign that something has bled, fibrosed. So you get layers of like kind of brightness and darkness based on what stage it is. And if anything's that actively bleeding, then it's bad news. Essentially, it's neoplastic. So target lesions are associated, 70% of them are neoplastic.
70. Yeah.
Sometimes I make up statistics. It's not deliberate.
Fun, isn't it?
Hey?
It's fun, isn't it?
Everyone
Fun.
likes numbers. Compared to my experience, that's the ballpark. No, I'm sure I've read that somewhere, but then sometimes I get
Yeah.
my studies
That makes
confused. And
sense.
yeah.
My
Um,
head had even more like 80 in my brain. So
okay. Okay. Ballpark. Yeah.
yeah.
That's probably two different studies we're quoting.
Yeah. Sure.
So that was happening in the brain, and you actually see that on MRI. So they've had a bleed, and then they like get edema from the bleed, and then they get fibrosis around where essentially that area that was kind of under pressure, the brain area, you lose that brain tissue, like all those brain cells, so you get this little focus of scarring in there, which is actually one of the mechanisms of epilepsy development. Little scars in the brain and stuff. Interestingly, we'll do a whole session on epilepsy. Anyway, so two different types of stroke, ischemic and hemorrhagic. Hemorrhagic are random because it kind of depends where the neoplasia is. So localizing a hemorrhagic stroke doesn't actually help you go, okay, that's probably a hemorrhagic stroke. but it not being on a common location that we see ischemic strokes might help you say it's probably not an ischemic
Mm,
stroke. So it might help you take
yeah.
that off the list. So ischemic strokes are from blood clots in circulation or foreign material in circulation, but you'd be pretty unlucky to get foreign material because
Mm,
pretty much it's obviously iatrogenic most commonly, like a catheter
yeah.
or something like that that breaks
Mm,
or someone snips accidentally or something like that. That's going to go into the venous system. It's going to go in probably into the right side of the heart and kick around in there, or it's going to land in the lungs. That's where
yeah.
venous from. So foreign to get a foreign body in an artery centrally, because pretty much the heart like there's a highway straight up to the brain. Like you can't really.
Yeah.
So foreign material has to kind of be a clot or like bacterial embolus or a fat embolus, like
Mm,
something that was already in circulation. Um, and that's going to block an artery. And because there's this highway that goes straight up, there's almost like a path of least resistance that most of the clots go to. So around about 50%, I actually got the stat, it's 47%, will go to the rostral cranial cerebellar artery.
oh,
So that
okay.
means that ischemic strokes actually present quite similarly, the same way, quite distinctively. And so you can almost say this is an ischemic stroke from the typical signs of cerebellar ataxia, acute. It has to be acute, otherwise it's not a stroke. Um, so cerebellar ataxia, which looks like what?
Uh, like tetrataxia, like
Yeah,
all,
so wobbliness. Yeah.
yeah.
So the cerebellum's responsible for inhibiting. Oh, it's coming back to me. Uh,
Mm.
so it inhibits the like when the vestibular system's controlling stuff, it really overdoes it. So the vestibular system so the cerebellum actually smooths down the signals going past it from the vestibular system and actually makes it smooth. So where you or I going side to side like this, we're in control of that. That's fine. Our vestibular system allows us to go like that without overreacting. Our cerebellum like stops that overreaction. So a dog with cerebellar ataxia is often doing this oscillatory like back and forth because the vestibular system's controlling everything. The cerebellum's not dampening down that kind of overreaction. So it's called an oscillatory muscle contraction. So they move side to side. Have you seen that intention tremor?
Yeah, yeah,
That side to
yeah.
sideness. So they just can't stay
Attention tremor.
smooth.
Yes.
Yeah.
Yeah, yeah,
Coming back to me. There we go.
yeah.
Uh, yeah, so rostral cerebellar, often cerebellar ataxia, often got an intention tremor. The other thing it's not smoothing is muscle. So they're hypermetric, really like high
Mm,
stepping gait because
mhm.
you don't have that kind of smoothness of movement. Um, what about their menace? What do you reckon is going to happen to their menace?
With cerebellar disease.
Mm,
Geez, I wouldn't have thought that it would have had much
it can
effect on it.
actually, yeah, we can
Mm,
lose menace, but our PLR should be perfect in that
mm,
situation. So it's actually quite a nice localizer
yeah.
because it doesn't impact the ocular pathways,
Yeah.
but it can decrease
The cranial
menace.
nerves. Yeah.
Yeah, exactly. So menace is a really complicated pathway actually, and it's often the first thing to go if there's like caudal forebrain cerebellar insult. So it's really helpful
Okay.
in these situations. It does depend how big the stroke is, because if it's just a tiny little, in humans they call them TIA, transient ischemic attack. So a little
Mm.
clot doesn't cause too much damage.
So can
Um,
I
mm,
ask that 47% stat, is that
mm.
specifically for an idiopathic is- ischemic stroke? I guess in GP, the most common times that I would be experiencing this would be like a fate in a cat, or
Or when I'm saying
is that
stroke,
like
it
different?
implies brain,
Specifically brain. Okay.
specifically
Okay.
brain. Exactly. So 47% of brain, like strokes specifically
Mm.
central nervous system.
Okay.
Um, I don't even know if it applies to the spine. It might just be brain. I haven't heard
Hmm.
the term like stroke applied to the spinal cord. I don't deal with spinal cords very often. Um, yeah, so arterial thromboembolic disease includes fate, includes um,
Mm.
like necrosis. We see it sometimes in like the splenic artery can sometimes get clotted, mesenteric artery sometimes gets clotted. So all of those are arterial thromboembolic disease, which presents quite differently from and has different underlying causes than venous thromboembolic disease.
Mm.
So if you think arterial system goes away from the heart, goes towards the periphery, so you're going to see signs at the tips, tip of the tongue, tip of the
Yeah.
ears, and where the vessels get small. So in the capillaries, the lungs, the kidneys, eyeballs get clots and stuff as well. Whereas venous strokes are coming back towards the center. So if you get a clot, like I used to work in a human hematology lab, and they were just like clots always come from the PTEs, always come from the legs. So a clot develops peripherally, and then circulation just gets caught up in circulation, and it comes back through the cava, right side of the heart, and then into the lungs.
Mm.
So venous thromboemboli typically present in the lungs. Arterial
Hmm.
thromboemboli present at the ends of the vessels.
Yeah.
So we might see them in the aorta, but yeah, in this situation, strokes. Um,
Be annoying. Do you know where you'd see cats or dogs on high dose pred where they
mhm.
would form an emboli? If that's arterial
um,
or venous or
I love this topic. That's an excellent question. I can talk to you about it for 4 hours. Cushing's dogs have, when I think about hypercoagulability, like predisposition to forming clots, whether it's arterial or venous, there's three factors. One is stasis. So this is Virchow's triad. You remember this?
Mm. Mm.
Mm-hmm. Mm-hmm. Stasis. So, like if you decrease circulation, if blood's pooling anywhere, you're going to get clots forming. If you have endothelial damage, which means that you're then activating all that clotting pathway,
Mhm.
so you've just got more activity of the clotting pathway, or if you've got hypercoagulability.
Mhm.
So stasis and endothelial damage, quite venous.
Mm.
I mean, endothelial damage does happen in the arteries from shearing, like just damage from like, if, for example, aortic stenosis, they get like aortic wall damage and stuff like that. But typically, we see venous clots in those two things. But hypercoagulability then is another list of three that causes hypercoagulability. So you can have increased procoagulant factors. You can have decreased anticoagulants.
Mhm.
So we've got a balance in our system of coagulation factors, but also anticoagulants, and they
Yeah.
have to be kind of at equilibrium to maintain
Yeah.
homeostasis. And then we've got poor fibrinolysis. So if we an appropriate clot develops, but then it just doesn't break down, and it stays for like four
Mm.
times longer than it
Mm.
should, then there's four times the chance that that's then going to disconnect from where it's lodged or where it's appropriate and get caught up in circulation. So
Yeah.
they're the kind of three things. So this is if you've got a patient that presents with an acute stroke, you know it's an arterial problem. So probably stasis isn't going to be something like a
Mm.
lot of the time the old dogs. But is there endothelial damage? So do we have like endocarditis or endocardiosis, which where there's damage to the lining of the heart? Is there like vasculitis or something like that going on? And is there an inflammatory disease going on? Because in inflammatory diseases or Cushing's, we see increased procoagulants, decreased anticoagulants. So that balance goes right out, in particularly in Cushing's. And then we also have increased platelet numbers in Cushing's as well. So there's more
Mm.
surfaces for clots to form on whilst just floating around in circulation. Because normally clots are localized. And we also get delayed fibrinolysis. So Cushing's gets the trifecta. And so they're prone to both venous and arterial clots. It was a very
Yeah.
long way around to answer your question.
No, that was good. Yeah.
Made sense. So
Yeah.
that. I do sort of think about that list of three. If I've got a dog that I'm like, could this be like a vascular injury? I'm going to think, are there underlying factors that increase procoagulants? Are there underlying factors that decrease anticoagulants? So most common anticoagulant is antithrombin.
Mhm.
Have you heard of that?
Yeah.
Yeah, so it's one of the proteins that gets lost really early in protein losing diseases, enteropathies, nephropathies.
Yes. Okay.
So in those patients, we see this drop in anticoagulants, and they're the ones that I've seen the most arterial clots in. So if
Mm,
they've got protein loss, that loss of anticoagulant, I think predisposes to arterial. We don't have that data in dogs, but that's my clinical instinct.
interesting.
Um, yeah. So I'm gonna just digress
Because I know
totally.
that we start that on all our PLE patients and PLN patients. Um,
Yes,
Also on
completely.
pred as well. So it's probably the
Yeah,
both. Yeah.
yeah, totally. So that pred will do exactly the same thing as endogenous,
Mm,
like Cushing's.
mm,
So I'm going to digress because I find this topic really interesting, and
mhm.
you have to do what I say. So uh, I'm going to draw you a picture. Arts and crafts time. Uh, so I started a PhD. I did like 7 years of a PhD and then had babies and stopped. Which my
7 years.
supervisor's dirty about. Hey,
7 years.
7 years, yeah, part time. Yeah, probably should have finished it in that time, but I didn't. So we looked at clots forming basically. So we developed a test where we could like get a dog's blood and like trigger a clot to form. So it's anticoagulated blood, but we could then like reverse the anticoagulant basically, and then watch the clot form. And you watch this clot form over time, and then you watch the clot break down, and you can then get information on whether they're more prone to clots forming, how long it takes a clot to form, and then whether that clot's staying around too long. And it was
Mhm.
so interesting. So Cushing's dogs. Oh no, wait. Are you gonna let me do it? No. Yeah. Okay. So we've got.
Cool. Am I on this as well?
Yeah. Get in line though. This is my show. Uh,
Fun.
we've got time across the bottom axis,
Mm.
and we've got like how big the clot is over this axis. So essentially, we've got the
Yep.
plate outside the machine. We activate clotting. We put the plate in the machine, and a normal dog will start from zero clot,
Hmm.
and then at about 5-6 minutes, it'll start to go up, and then it'll stay up, and then it'll come back down again, and then it just
Mm.
fades away to nothing. So that's a kind
Yeah.
of pretty normal curve. Dogs
Mm.
with Cushing's, weirdly, will often be delayed for a clot to
Mm.
form. Clots will be about twice the strength, so twice the amount of fibrin, and then they just stay like this.
Mm.
So we did about 40 dogs with Cushing's and then never published it. So I know this, but nobody else does. Um, Somebody else has published a similar study since, so I didn't make it up. I know I didn't make it up. Um, Dogs with protein losing enteropathies, I couldn't get the plate into the machine fast enough to catch the beginning of clot formation. So the curve would start
Very
here,
quick.
it would
Yeah.
go like sky high and then come right back down again. So when you've got that speed of clot formation, like normally the arterial system, just like the clot doesn't get strong enough or big enough, fast enough for the turbulence in the arterial system to like stay there. Whereas these dogs with protein losing enteropathies, nephropathies, where they've lost their endogenous anticoagulants, the clot forms so fast. And that
Mm.
means that it's much more likely to form in an arterial system. Does that make
Yeah.
sense?
Right. Okay. Yes, it does.
Yeah.
Yeah.
So these are the dogs that are really high risk for strokes. Systemic
Mm.
inflammatory disease can do really similar. And I had one dog, N=1, so probably not accurate, but a dog with a FAO, but the FAO was in the blood vessel, in the cava,
Yeah. Yeah.
like it had invaded. And so there was so much endothelial damage, there was so much activation of clotting that looked similar to that as well, that really,
Mm.
really hypercoagulable. And actually, we took that tumour out and sent it off for histo, and the dog had an arterial thromboembolism to the tumour and killed off the tumour.
Oh,
Like it was
wow.
actually mostly necrotic because it
Because
had
there's so
clotted.
much turbulence at
Yeah,
that area as well that it's gonna,
yeah,
yeah,
yeah. It
interesting.
was amazing.
Yeah.
Um. Anyway, I'm going to stop. Close Bible. There we go. Okay, arts and
Yes,
crafts
that's
time over.
interesting. He said dogs with Cushing's have are more pro-coagulable, but they're still delayed clot formation, and it just resulted in the strength of the clot was really
Yeah,
strong.
much stronger clot and a clot that's stuck around for like 8 to 20 times longer than a normal clot. So
Wow.
that's a very venous, like that's very much what I'd expect to see. You know, like do you know when there's a little bit of stasis, they're lying around, they might like have like a big left atrium causing a little bit of stasis in the left
Mm.
auricle as
Yeah.
well. And then you just get this clot that's just got time to just brew over time and then just get caught up in. So dogs with Cushing's are really prone to venous, less prone to the arterial, but they do still have that lower anticoagulant level than other
Mm.
dogs, so that still happens. So any underlying diseases that might contribute to an imbalance in those factors, I would say, okay, well, this is much more likely to be a stroke now.
Yeah.
Um, that was a really long way around. Sorry, I digressed. Um, so, number one artery that gets hit by strokes causes that cerebellar ataxia, cerebellar signs. Um, and they've typically got pretty normal mentation when that happens.
Mm.
Um, the second most likely, and that's like 47% and then 42%, so we still see this quite commonly, is the rostral brainstem, thalamic and rostral brainstem perforating arteries. And this is where we get proprioceptive deficits.
Yeah, okay.
If you can get the dog like stabilized in a standing position with their weight completely supported, that's a big differentiator between the cerebellar
Mm.
presentation and this presentation. So brainstem's very important, obviously. Does a lot of important jobs. So this actually carries a worse prognosis than the cerebellar ones actually do really well. 2 days they're usually fine. Sometimes a week. The ones that have dull mentation, central vestibular, so that vertical slow nystagmus, or it can be horizontal, but if it's slow, particularly if those dogs who've got that slow nystagmus, if you roll them onto their side and it changes to like one eye doing this and one eye doing this, you know it's central. And
Mm.
often they'll look peripheral when they're sitting up like this, and then you roll them on their back, and all of a sudden it's like, oh, clearly vertical.
Yeah, yeah.
So that's a nice tip as well to help differentiate. And they often have these guys often have multiple cranial nerve abnormalities, so we might lose menis as well, but we'll also potentially lose palpebral and other like facial trigeminal and glossopharyngeal.
Yeah. The only brainstem tumor I've ever seen was swallowing problems. Um,
Interesting.
really vague signs, but dullness, bit of dullness as
Mm.
well. And um, I'd never seen anything like it. And then yeah, CT
Amazing.
was brainstem tumor, and I was like, that makes sense.
There it is. Yeah.
Yeah.
CT, MR, CT.
think it was CT. Yeah.
Yeah. So that's the one thing with diagnostic tests. When something localizes to the brainstem, there's such a dense bone, like that occipital bone, and where it kind of meets the spine and stuff. CT, you get an artifact from bone. So sometimes in that brainstem, which is actually quite small and surrounded by very thick bone, it's less diagnostic for tumours.
Mm.
And the other thing is because the brainstem's quite small and there's not a lot of extra space in there. If the tumours are smaller when we see clinical signs than the forebrain lesions. So where CT is not as sensitive as MRI for a brain tumour, it's fine for a forebrain lesion because the forebrain lesions are definitely big enough to see, whereas brainstem lesions can actually be quite small. So if you've got an owner that's like, I'll do whatever you say is the best thing, and it's localizing to the brainstem, I would probably say let's go for MRI if we can.
Yeah.
Yeah. Still not the wrong thing to do CT if the owners
Mm.
will, but we just need to understand the limitations of that. Most of the CTs are so good now, and the way that they can kind of manipulate the images afterwards, they're pretty good. Um, the next most common are called lacuna infarcts, and they're the typical kind of TIA kind of presentation. They just can cause intermittent loss of proprioceptive deficits or like unilateral motor. So they're the ones that are often a bit like torticollis and might be like crab walking.
Mm.
You're gonna have to
Well,
look
yeah,
at that
I'm
when you
learning
say
that
it.
word
I'm
now.
gonna need to write it. I'm gonna write it down so you can see it. Am I? Make sense?
Torticollis. Tor-
Torticollis. Torticollis.
Yeah.
It's the body bend. I need you to. Oh, can you Google it?
Yeah.
Just Google images because it's a really distinctive presentation. Everybody needs to Google it. Have a look at what torticollis is and tell me if I'm saying it right. So they're the most common stroke presentations. So you can, if you see something that's quite distinctive in those like acute onset, older dog, predisposed to clots, I often say to clients, they're probably going to be okay in a couple of days. Let's use that as the diagnostic test, and if let's support them through this, obviously whatever they need. But if they're not better in 48 hours, then we can go to imaging. That's a big part of my diagnostic process with acute onset. If they're not seizuring and in status and stuff, obviously it's more urgent. And something that I sort of keep in mind is, okay, if the supportive care is going to cost more than the imaging, I would say let's put like the accelerator on the imaging, because
Mm.
you might get 4 days in hospital and spend 12 grand, particularly if they're seizuring and needing like a lot of intervention. Whereas imaging, the owners can then make a decision based on prognosis if they're not ready to just make a call without knowing. We didn't talk much about brain tumours. I don't think we need to. Radiation's nice now. It does, now that there's an option for treatment other than surgery, if the clients are open to it. It can be helpful. Any other questions? We might wrap up.
No, I don't think so.
Otherwise, I'm going to go down another rabbit warren, and we're going to be here for another half hour, and both of us need to work today.
That's true.
Mm.
Yes. Oh, it's already 9. Okay.
Yeah, it's time.
Mm.
So hopefully we covered some helpful hints for GP
Mm.
neuro, and I think that ischemic stroke side is probably the most common thing we see, apart from like the slow onset dullness brain tumor kind of presentation. So it's nice to be able to kind of have a few things that make you go, yes, this is what this is. This is localized into this. I think it's a rostral cerebellar lacuna artery. Sounds really fancy. And we'll see you in a fortnight. I'll see you sooner.
You will see me much sooner, I'm sure.
Much sooner.